Welcome to the presentation on listening to chronically ill patients in face-to-face and virtual patient-doctor interactions. I am Dr. Leslie Ramos Salazar, an associate and Abdullat professor of business communication and decision management at West Texas A&M University. First off, a topic that I looked into was the rise of chronic illness. Now, according to the CDC, 45% of individuals suffer from one or more chronic illnesses. First, heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease, diabetes, and chronic kidney disease. Now, because of the pandemic, as we know, was very traumatic and there was a lot of negative healthcare effects, that the chronic illness has been increasing. And also, the pandemic also led to much mortality from those with chronic illnesses. Now, patient physician miscommunication is a common theme across healthcare, part of it because it leads to so many negative healthcare outcomes. So, for example, patient physician miscommunication leads to malpractice complaints. According to ION 2017, complaints can occur because of misdiagnosis, improper treatment, or maybe wrong medical billing, stuff like that. So malpractice complaints are very common. And second of all, the medical errors during the diagnosis and the treatment, according to the CARMAC 2017. So these medical errors do increase the more miscommunication that occurs in a healthcare context. Now, there is patient-physician communication competence. This involves effective listening in face-to-face settings. This could be a doctor office, and virtual environments such as video conferencing technologies such as Zoom, Google Hangouts, Microsoft Teams. Now, there's two processes involved. First off, there's the encoding process. This is where a physician can send a message to the patient, or a patient can send a message back to the provider. Now, there's also the decoding process where the physician can receive messages and listen, and also the provider simultaneously can also listen. So the simple model that's based on communication out there is the linear model that just focuses on sender one way, receiver this way. But nowadays we have a more advanced model that we argue that it's possible that a physician can engage in both the encoding and decoding process, and so can the patient. So that means while you're sending a message, you're also listening. Where you're receiving a message, you're also listening, but also sending messages. So this means that listening is always happening in patient-physician communication. Like, it just doesn't stop. And there's positive healthcare outcomes due to the patient-physician communication competence. The first one is open communication. This is where the self-disclosure is enhanced or improved. The open communication, you can tell because the flow is very effective. The trust is also a key factor to effective healthcare relationships, and also accurate exchanges of information, because remember, without accuracy, that could lead to problems. And enhance patient satisfaction. The patients report being more satisfied with the overall experience, happy with their physician, and the physician also report high job satisfaction. They're also less vulnerable to lawsuits. As we know, lawsuits are best prevented because they're more cost effective. So that could be positive. Also, an overall increased quality of care. Now, I looked at the listening styles in healthcare from Barker and Watson 2000. Now, this listening style profile has 4 different types of listening. The first one is people listening. So this one looks at paying attention to patients' intentions, moods, and emotions. So in a healthcare setting, it's all other-centered. They focus on the other person, not the self. So it's about the other. So that's where we really clue in into another, what they're feeling and stuff like that. The content-oriented listening is about evaluating evidence from messages. So a physician might evaluate the messages from a patient saying, maybe this patient is not ready for this type of treatments. And from a patient perspective, they might be evaluating, maybe that treatment, I have questions, or I'm not thinking, what does it entail, pros and cons. So content is all about the message. Whereas action listening is about noticing errors and inconsistencies in conversation. So there's a little bit of skeptical going on there. So there's a little bit of skepticism because they're like, okay, I notice inconsistency with the nonverbal communication and this other thing that was said. So they kind of look for that. Time listening, on the other hand, is paying attention to the time during conversation. So now we have mindfulness in time. So if we engage in that, we can be conscious of the time during the interaction. Is it happening too quickly? Is it happening too slowly? So in healthcare, we know that office visits can sometimes be just 15 minutes every slot, or sometimes they'll have a little slightly longer, 20 minutes. It just depends on the healthcare facility, the healthcare provider, and their kind of rules. So that's important in the healthcare as well. Now, medical communication competence was developed by Segala, 1998, and they include patients' information giving behavior. So, this is when the patient gives information about their healthcare condition or about symptoms and stuff like that. So, in the face to face context, this includes sharing information, giving behavior. So, this could be sharing information about a health condition during a physical office visit through self-disclosure, or online sharing information using communication technology such as webcam, microphone, and chat features. The second component, patients' information seeking behavior. So in the face-to-face context, it's asking questions to the doctor during the office visit, or asking a relative or a friend who also faced a similar health challenge, or reading traditional pamphlets. Whereas the online is about searching for health information like treatment symptoms via the internet. Now, individuals use Dr. Google to search out what conditions are out there and about their illness. They even go to YouTube and search for videos that are relevant. Now, that could be sometimes problematic because sometimes the health literacy skills are not there from the patient perspective, given the lack of education in that area. So we have to be careful. The third is patient's information verifying behavior. This is crucial because this is where we ensure accuracy. So in face-to-face, this could mean checking for understanding of a prescription at the office, whereas online, checking for understanding but using communication technology such as chat, microphone, webcam. Now, sometimes checking for understanding using communication technology could be a little challenging because it's happening so quickly and sometimes they're still learning the technology. And fourth, patient's information, social emotional communication. So in face to face, this is where relationships are developed in person, the trust, the warmth, the empathy. Whereas online, the relationships are developed online. So now this is interesting. So there's some literature that argues that relationships are very difficult to develop online because of the barriers of not having other nonverbal cues. So they argue that it's kind of difficult to establish trust with using these technologies. However, there's also other literature that says because of the online disinhibition effect, that patients feel more comfortable in just disclosing about their healthcare conditions and their stories. So because they don't have the person right there, they just kind of feel more open to that. But it really depends on the skill level of the patients. So what I did was a survey research study looking at 522 patients using Qualtrics. It was about a 20 to 25 minute survey, and I used two scales. I used the listening styles profile, and I also used the medical communication competence. Both of them are validated and they were shown to be reliable. The analysis I conducted was using regression. So overall, I'm just going to share the findings overall. The first finding was that people and time listening positively predicted information giving behavior. And you could think about why. So people listening is about being in tune with the other person, and time listening is all about being conscious of the time. So they were able to just share more information. Whereas action listening was inversely related to information giving. And it makes sense because they're kind of looking for errors and inconsistency instead. Now, another finding was that people, content, and time listening positively predicted information receiving. So these three different listening styles actually predicted receiving different types of healthcare information. So they were kind of more open to it during those healthcare conversations. However, action listening was inversely related. So, in a sense, they were so busy paying attention to inconsistencies and errors that the information would kind of come in one ear and then go off the other. And another finding was that people in time listening positively predicted information verifying. So these two listening styles indicated that they were more likely to ensure accuracy occurred when exchanging healthcare messages. Action listening, once again, inversely related to information verifying, so they were less likely to engage in that verifying behavior. People, content, and time listening positively predicted social emotional communication, whereas the action listening was inversely related. Part of it because when we think about social emotional communication, you're exchanging different feelings during those healthcare conversations. So maybe for that reason, the other styles of listening were more effective. So there are several implications from this study. The first one was that people and content listening are the most effective approaches when interacting with patients with chronic illness, whether in person or online. And remember, people is about being in tune with the other person, and content is about the message and looking into that during the conversation. So those were the most effective styles. So when we think about the healthcare information that could be exchanged, it could be a healthcare condition, it could be the diagnosis or treatments. Also, it's effective in establishing or nurturing doctor-patient relationships, so that could be kind of good. Now, when we look at action listening, it was actually ineffective when interacting with patients with chronic illness, regardless of the medium. Part of it because action listening is about looking for errors and inconsistencies during the conversations. So that's not an effective approach, at least in the study. Time listening had mixed results. There was some times where it actually did predict effective healthcare information exchange processes, but then it just depends how it's used. So, for instance, rushing conversations during an office visit and looking at the clock all the time, that could come across as not caring for the patient or a lack of empathy. And it's also difficult to develop doctor patient relationships. As we know, trust and warmth and openness take time to develop. The future research directions are as follows: observational research comparing face to face and online listening and healthcare interactions is needed. This can be conducted very simply by going through IRB, but also recording the office visits. So you would record the face to face healthcare interactions and also record the virtual dynamics going on, and you would develop a coding book and then develop themes that are based on listening to kind of see similarities and differences. And second of all, longitudinal research is very important in listening, so we can look at the effects of listening on patients' well-being and overall communication competence. So it's kind of important to look at the listening process over time. That could be 5 years, 10 years, 15 years, whatever is realistic for a healthcare facility. Third, while I did use validated scales, there is still a need to develop new validated listening measurements that are tailored to the healthcare context. So that might look at perhaps different styles of listening. Maybe there's new ones that are more relevant to healthcare. So that is an opportunity there. So that was my presentation, and if you have any questions, feel free to contact me at lsalazar@wtamu.edu, and thank you. I look forward to your presentations as well.